So we're going to talk about Medicare enrollment information and specifically the Master Beneficiary Summary File. So what we're going to talk about, again, just a reminder with all of these, there will be time for questions at the end. We're also monitoring chat and Q&A. So again, hopefully we can make sure that if you have questions as we go, that we answer them when possible. And in fact, if you give me just a minute, I am going to open up the Q&A and I'm going to open up the chat so that we are good. So now, if I did this right, I'm back. So you'll sometimes hear me slip, and I just have to warn this, just like I'll sometimes call this the denominator, which is not precise. And only when you've been part of in ResDAC as long as I have, and I still don't get a pass on being imprecise. Because it's going to be very important when you work with CMS that you always use the exact file names and the exact variables. Sometimes there'll be things that sound really similar, so we have to use the right thing. But the Master Beni Summary File briefly is a file that has one line for each beneficiary enrolled in the Medicare program at any point during the calendar year. In this file, and it's actually should be updated, to be honest, to say a set of files. The files contain the details about their enrollment, the beneficiary demographic information, and some summary information from claims. So that is briefly what the files contain. Now, first of all, I just want to stop and remind everybody, and this is a bit of my training as an epidemiologist, and it's a bit of lessons that I've learned over the years. So sometimes people will say, well, look, I really want to look at hospitalized people. Do I really need this denominator thing anyway? And the reasons to use a denominator file, first of all, if you're going to want to follow a cohort over time or a group of people, a panel, you can call it whatever you want. The reality is you just need to be able to understand why they disappear or appear. So for example, if you see somebody who doesn't have healthcare use, there's two explanations. I mean, there are multiple explanations, let's be real, but one explanation is that they're dead. And CMS does not provide healthcare for dead people. Another one would be that it was, that they transitioned to managed care because it's the end of the year, and therefore we're not going to see them in our files. And another one is they didn't use it. Now, those all are going to result in very, very different inference. So it's really important that you be able to have the information to say, am I really likely to see what's going on with this person and interpreting it correctly? Likewise, if you want to track beneficiaries from Part A services to Part B services, you need to know whether they have Part B coverage. And that may sound really basic, but it really does happen. If you're studying beneficiaries who receive benefits through ESRD or disability, you need to track it because sometimes disability, as somebody asked this morning, you can lose disability benefits after a kidney transplant, after some period of time. They're no longer eligible to receive Medicare benefits under the ESRD program. And finally, and this has happened surprising a number of times, is if you're combining data with an outside source, you want to be able to confirm that you actually linked. So otherwise, again, it's this idea of knowing what you know and knowing what you don't know and being able to track that as you go. So over time, this is part of the reason for the slippage. And actually the data, this is wrong. So when I first started using these data in the early 90s, we had the denominator file, and it was literally a file that was 69 columns wide. It was a very narrow little file. We could pull it up on a screen. We could look up a case, and it was really simple to work with. Now, things have expanded. The names have changed. We went from denominator to beneficiary annual summary file to beneficiary summary file to Master Beni summary file to denominator with Part D. And so sort of like managed care, this file gets renamed from time to time. And it's effectively the same idea, which is we need to be able to know who's in our population and we need to know things about them. So we've got the Master Beni summary file. And it's got 5 segments. So this is this piece, and I'll be the first to warn you about it. And Sammy will be talking about it more tomorrow when she talks about creating an analytical file. But what CMS is doing more and more is taking, and rather than having really massive files, they're breaking the files up into segments. And that's both good and in some cases not so good, because it means some parts of what you do are going to be a little bit trickier. What we have in the Master Benny summary files, we have what's called the base record, or sometimes it's called the ABCD record. And as you might be able to guess, that's got the basic information, the enrollment, ABCD. It's got demographics. And so it's got sort of the most birth date, death date, the information that you need. There's also a segment called chronic conditions and another one called other chronic conditions. And Nate will be talking about those tomorrow around noon, and what those contain. But those contain chronic condition flags, so you can use those as a way to figure out what's wrong with people and to pull a disease cohort you choose. There's also a segment called cost and utilization, and what that segment does is summarizes information from the claims. And so it's got summaries like all variables that other people create. It can be easy to say, well, they didn't create it exactly as I wanted. I will warn you, nobody creates variables exactly as you want, including yourself. But this is the fourth segment. And then there's a national death index linkage. And the national death index linkage is a huge benefit for us. And it's very exciting, I think, because it means we can not just look at what happened in terms of status, but we can also try to get some idea of why they are not, for example, why somebody died and whether it was related to a primary condition or something else. You can look at underlying conditions. The big thing that we'll link to later on is the ICD data. The cause of death data is only available through what's called the Virtual Data Research Center, which is an online way to access the data. In other words, you cannot get this information shipped in physical files. So at some point, when you try to figure out, when we talk about putting it all together in analytic files and how you're organizing it, this may be a factor that really influences how you choose to get the data. So creating the denominator file or the Master Benny summary file, what we do, what CMS does is they combine data from a variety of sources into what is now called the common Medicare environment. This is a massive database. They take information they get from Social Security, including Social Security eligibility, payments, so on. They get information from the managed care organizations about whether somebody is associated with that managed care. There's Railroad Retirement Board, which is less common now, but is sort of a parallel retirement system that came up in the US, parallel to the Social Security Administration. And so a few people still get their benefits coordinated through the Railroad Retirement Board. From states, so remember we talked this morning about how states, what's called state buy-in, where the state helps with premiums, co-pays, and deductibles in Medicaid. The states input that information. And then from claims, things are known and validated. And so that all gets put into this common Medicare environment. And that Medicare environment is an internal data set. If you see old versions of things like managed care, this environment has been renamed a couple of times. But it's the same idea. It's just a massive database that is not ever released out to the public. But what happens then is that there's an extract from the common Medicare environment, and that extract is called the Master Beneficiary Summary File. So that is what happens. So this internal data is used to create flags, to create status variables, and some of those variables are extracted and released. So the common Medicare environment is, again, as I said, is from multiple sources. It contains eligibility, enrollment for every beneficiary, in theory, ever entitled to Medicare. And then once a year, there's an extract, and that is what we get. When you take the file, when you think about variables in the file, one of the challenges that happens is this idea that I'm going to call date stamping, which is that things are created as an individual field that aren't necessarily unchanging. So, for example, residency. People can change their residence. The question is, how often do they change it, and how do we need to know? So in some cases, when you have these apparent mismatches or apparently inconsistent information, the problem isn't that the information is wrong. The problem is that they're not from the same point in time. As an example, and we'll go through it, whether you consider date, when we say, oh, I want everybody aged 65 and older, right? That's one of our classic things. You've heard me say it a million times. Nate said it. But the question that you should all be thinking in your head is 65 and older when? So for example, if I say 65 and older on January 1st, 2021, then everybody who turns 65 during 2021 will be, after the first, will be excluded. But if I said 65 and older at any point in 2021, there will be people where most of their observation time, they're not actually eligible for Medicare. So even a simple question like, how old are they, is not a simple question. And so what happens is that when you look at date values or you look at values for residency or benefits, you've got to make sure you ask, well, what is the time frame this covers, and how can I know? And if I'm getting conflicting information, is it that my information is inconsistent, or is it that they're applying to different points in time? So with date stamps, the most common options are the first value in a calendar year, the last value. And it used to be, in the 90s in particular, through the early 2000s, the value for the denominator file was frequently the value that was noted when the file was created. So if the file is created a year after the end of the observation period, some information might be out of date by up to a year. So when you look at elements and when you compare the MBSF information to the claims, you really have to stop sometimes and do this step and ask yourself, am I in fact measuring at the same point in time, or am I comparing things measured at 2 points in time? So in terms of included individuals and identifiers, so who is included in the MBSF? So as I said, this is an annual file, and all beneficiaries enrolled for even 1 day in the file are included. So it isn't limited to people who use services. It's anybody who receives that Medicare card, who's enrolled. If you want to limit to new users, you'll have to use selection criteria to find them. It's actually not an easy selection criteria to figure it out, but again, it's certainly doable, but it will give you everybody. So you have to think about if you want new users, how am I going to do it? There's in fact no indicator for new beneficiaries. You're going to have to create a logic rule to find those new people. As a reminder, eligibility for Medicare is actually not determined by Medicare. It's determined by the Social Security Administration and the Railroad Retirement Board. So this is not something where you can say CMS did it wrong. CMS doesn't do it. Social Security and the Railroad Retirement Board does. And again, this file, the MBSF, don't forget, it includes all benefit groups. So unless you say, I only want old age, I only want the elderly, or I only want the disabled, you will get everybody and you'll have to sort it out. So if you remember the last segment where Nate was talking about deciding whose data you want to ask for and what you want to keep, these are places where you might be making a very simple decision. I only want the elderly, or I only want disabled, or I want everybody. A question came up earlier, and it's always a question about Medicare and how do you find a person? How do you make sure that you're looking at the same person? And I'm going to give you a little bit of history here, mostly so that if you go in and do some reading, it will help you put everything together and make sense of it. So there's two parts of it. There's the part of the Medicare that the beneficiaries themselves got. And before 2018, there was what was called the HIC, which was a health insurance claim number. It's an 11-digit number that was most typically a 9-digit Social Security number with a 2-digit identifier explaining how the person related to the Social Security number. So as an example, if I had Medicare benefits and before 2018, and I got the benefits because of my own work history, the 9-digit CAN would be my Social Security number, And the 2-digit beneficiary identification code would be, I believe it's an A and a blank, which says, my social security number, I got it based on my work history. But likewise, what can happen is if in fact I got it based on my husband's work history before 2018, it would be his social security number because I'm using his work history to get it. And the 2-digit BIC would be a B and a blank saying spouse. And you can have multiple spouses, you can have disabled children, this was a way to identify both what was the basis for receiving these benefits, which work history used it, and how it was the relationship for the person who got the benefit relative to everybody else. Now, this is what happened on the Medicare cards. So when somebody went to a clinic and said, I've got my Medicare card, this is what they would see. What happened is there was a lot of fraud with the elderly. And this is a social security number. People were carrying it around. People were losing the cards. They'd get their pocket picked. And so there was a lot of concern that the identifiers, the social security number, was putting people at risk for identity theft without any real benefit. So what happened starting in 2018 is they created what was called a new beneficiary identifier, and it was a random number without any embedded information. So now if you were to look at your grandparents, at your parents, at your aunt's social security card, there's no embedded information. And if they lose their social security card, it's a pain, but they don't have to worry about anything else going along with it. But I'm telling you this for history, because the reality is, unless you're trying to link clinical data to Medicare data as a researcher, you will never get these information anyway. CMS has not delivered this data to researchers in about 15 years, and it is wonderful. And as a researcher, I am thrilled and grateful. It has made my life easier, and it should make all of yours easier as well, because it means we don't have a random number, as long as it's consistent and unique, is just as effective for putting together records as a number with embedded meaning. But it means that I have less worry about breaches, about maintaining confidentiality. I got less pushback from the IRB when I would put in a request, because there was no social security number, which is one of the HIPAA identifiers, and it's a biggie. So I'm telling you this for history, so you understand, because what was happening is people would say, there used to be this thing called the HIC, and now there's an MBI, and how am I going to be able to run my study that crosses this transition period? And the answer is, this is history. This has to do with clinical care. It doesn't actually have to do with your study, but it's really important, I believe, that everybody understands it. So for researchers, for us, what we get is what's called the Benny ID. And the Benny ID is a unique identifier for each study. So what it means is, if I put in a data request and I get my data, I'm going to get Benny IDs that are unique to my study. And then if Steph puts in her study with completely different cohort, she will get completely different Benny IDs. Now, what can happen is different studies can have records with the same Benny ID, the same random number, but if we were to put them together, we would not be linking the same person across my data and her data. We would, in fact, be combining different people. So they are not the same person, they're just the same person, so you have the same random number. So that's an important thing. So it's a protection. It means that it limits risk of data sharing without permission, because you can't. But within a study, it is stable. So even across the transition from HICS to MBI, between an original data request and requesting new data and saying I need another year, 3 years worth of data, the same Benny ID will hold. What that does mean, and just more as a quick reminder, if you have a cohort or a study and you want to update it, you need to let everybody know that, so it can be part of your request, because otherwise you won't be able to link the first data shipment to the second. But this is how it is done. So we use the Benny ID. It's an identifier. It will be consistent across every record in your study, as long as that was your direction to CMS or to the CCW. and you don't need to worry about transitions from HICS to MBIs or anything else. So the Beni ID is used for linking within files and across files. So for example, the same Beni ID will allow you to link your Master Beni Summary File records to your institutional files. So I can link, so I would use Beni ID to combine my Master Beni Summary File with hospice records to ask what percentage of people who die use hospice before death. That is how I do it. I would use the Beni ID to do it. Likewise, the non-institutional files like the carrier would link to the institutional files via the Beni ID. So this is the master linkage variable. And you will see increasingly on our website, we will say key identifiers Beni ID, and we'll make it really clear what are the variables, because in some cases, mostly for facilities, you don't always have the same identifiers, but this is key. And every file that has individual level data, I think every file, I can't think right now of any exceptions, will have that variable on it. So when we think about the MBSF, the base segment, the ABCD, one of the things it has the demographics. It has age, date of birth, gender or sex, race, place of residence, and date of death. The demographic information is largely reliable and valid. And so if you remember, reliable is, do you get the same thing over and over again? If I ask for the same file 3 times, will I get the same, for the same person, will I get the same answer? And the answer is yes, because it's from CMS. You don't need to worry that one clinic has the wrong date of birth compared to another, because this is from CMS and these are central and consistent. Valid, because sometimes there are mistakes, and we'll talk about that. That's one of those questions we always have to ask, is how accurate do we think this is, and how can we make sure we don't overinterpret what's going on? So beneficiary sex. Sex is coded. 1 is male, 2 is female. And then they have this thing in the record layout says 0 is unknown. And the first time I saw that, I just about screamed. I'm like, how can you not know? I mean, what do we do with them? And what we found when we actually went in and looked is, although the code book says 0 is unknown, there were fewer than 11 unknowns out of 60 million people. So the answer is 1 is male, 2 is female. And you really don't need to worry about unknown. So there are no missing values for the field, but we do still have to ask our next question, which is the variable accurate? So you might hear stories like this. Well, you see things that are impossible. You see men with endometrial cancer and you see women with prostate cancer. And the answer is you'll see minuscule mismatch. So when we looked at prostate cancer, we found 0.02%. So think about that 0.02% of people with their sex coded as female will have a diagnosis for prostate cancer. Likewise, 0.03% of records using the chronic condition flags had a sex for male, but a cancer that is very gender related. So there are a couple of ways of looking at it. One of them is, sort of to quote Jimmy Neutron, for those of you whose kids may have watched it, 95% is still an A. 0.03% of 60 million is going to be a big number, but as a percentage, it really doesn't matter. It's within the realm of random error. But if you care, you can go in and clean it all out. And I'm not going to pretend like there's never been any sign that anything isn't perfect. But for me, my view has always been, if I can get 99.98% consistency, I'm super comfortable with it. The question is, how does it, Abby, I'll answer your question later. Age is now listed as the oldest the person could be. So this is like a mind game, right? So it's their age at the end of the calendar year or age at death. So if somebody is 65, it means they either were 65 by the end of the calendar year, or it means they were 65 when they died, when they might have died before the end of the calendar year. So age is a shorthand, if you will. And the question, and often if you care about precise age, you can calculate it yourself with date of birth. But if you don't care about it, if that's close enough, you can use age. There are persistent concerns, and this is one I do want to acknowledge, that some deaths have been missed by the Medicare program. And so, some people are not listed as dead, and you're like, well, this makes no sense. We can talk about zombie jokes. I think there used to be an Onion article, an Onion headline about that if you do that. And in fact, compared to the census, and this is 2010, we need to update it. Starting at age 90, there were more Medicare beneficiaries between 90 and 94 than the census reported. Likewise, 95 to 99, but particularly over age 100. Now, some of those things could be a zero float thing, so when we start to get wrapping of, is this somebody who was from the wrong calendar year? So did they do a mistake there? Or is this a death that was missed? So we started looking into this, and this is one of these pieces as a tool I really suggest you to do, which is to do some logic checks. And I think this would probably technically, Nate's our methods person, fall under face validity checks. So we don't know for sure, but we sort of are looking for consistency and saying, based on what we're seeing, can I live with the story? And so what we found is that for people aged 90 to 94, that there was a very, very small percentage of people who had no healthcare use and no Part B use. So in other words, these would be people who never had any care and in some cases chose not to pay the premiums. Because if you remember, Part B, it costs money, you've got to pay. And we see a higher percentage with 95 to 99-year-olds. But again, if you remember, the overcounting from Medicare was greatest then. And by the time we get to age 100 plus, where we saw that the mismatch between the census and what Medicare had was the greatest, we also see a measurable percentage of people 100 years and older who in the calendar year of question had no healthcare use, and almost an equal amount didn't even have Part B coverage. So what we think is going on there is there is no money, being sent out. These are records because nobody has gotten fully around to investigating these mystery people. And so the theory is there's no financial issue with leaving it the way it is. But these are checks that you can do. So from our read on it, we said, well, we're going to be okay because one of my standard requirements for just about everything I do is you have to have Part B coverage. And so by having Part B coverage, I'm probably catching some of these people who never have any, who probably their deaths were missed perhaps even 20 years ago. But these are things you might want to look at, and especially if you're seeing problems or patterns that don't seem right, consider looking for internal consistency across different measures to sort of say, well, what would a person who is alive look like? So just to remind you, so first of all, I have yet to see anybody address this in a methods section. This is one of those where I don't think anybody in a methods section wants to say, and because I think Medicare has too many people, I did this, because it would make it impossible to get your article published. So this is just stuff people do and they hope they never have to explain. I'm saying that as a researcher. There's no standard way to remove these people or even consistent practice about whether you should or how you should. I personally say, we can get silly and say, well, anyone older than the oldest person in the United States should be deleted. Personally, I would do either anyone over some age 100 who doesn't have a single healthcare visit a year could be removed because they probably aren't alive, because it's hard to imagine them not getting anything at all. Or anyone over a certain age who doesn't have Part B coverage. Or you can do like what I do, which is because I'm requiring Part B coverage for most of my studies anyway, this problem is sort of solved by other restrictions. But please keep in mind that this is a super small number. This is less than 0.5%, of people who are 100 and older. And of those, maybe it shouldn't be that quite a big of a number. So it's not a massive problem, but it is something you will see. And it's really easy to get caught and say, oh my gosh, I'm seeing these things now, I can't trust anything. Again, if you consider 60 million people having a 0.5% or 0.25% or 1/3%, or 0.03%, with crazy numbers is well within what we would expect if we were doing primary data collection. So considerations for date of death. This is the next thing. And this is one that is certainly changing over time. And this is when we talked earlier about sort of secular trends. This is an example where there might be a secular trend that you want to watch for. So the way it works is the Social Security Administration and the Railroad Retirement Board are the source of date of death information. You'll sometimes hear this, and what happens is claims are used to identify beneficiaries who might have died to trigger an investigation to find out whether they have. So they're gathered from hospitalization claims indicating a patient has died in a hospital. And then it's a crazy letter, but you get a letter saying, either please confirm you were alive, with the idea that dead people don't answer letters, or we've received information that you might have died. If you are still alive, please let us know. And it begins a confirmation process. One time where these may occasionally happen is with large retirement homes, where there may be, more than one, Joe Anderson. And in which case, if one Joe Anderson at a large retirement home dies, the other Joe Anderson might get a letter saying, please confirm your vital status. Because it's like, well, this is Joe L. Anderson, not Joe P. Anderson kind of thing. But that's the process, that's how it happens. In the data, death dates, but again, no one is declared dead until a death certificate is received. So the idea is that because these are benefits, they don't really want to turn off benefits until they are sure that it's actually correct. So death dates in the file will be missing if the beneficiary is alive, and they'll be non-missing if the beneficiary is deceased. So what used to happen, and this is the secular trend, is it used to be that if a death certificate wasn't obtained, the death would be set to the end of the month, with the idea being that this is an insurance company. We don't want to say that somebody died when they didn't, and we don't want to cut off benefits early. So if we're going to make a mistake, we're going to set it to the end of the month rather than in the middle, which would be on average correct, or the first of the month. And so you can see what was happening, if you look at this graph, is the red line is the Railroad Retirement Board. And before about 2011, the Railroad Retirement Board and Social Security weren't doing a great job communicating with each other. And about 30% of Railroad Retirement Board data were missing. We're missing an exact date of death. They were sent to the end of the month. Something happened, I don't quite know what, but by 2013, 99.5% of deaths submitted to the Railroad Retirement Board were validated, as were the same percentage of deaths with Social Security. So this was a case where government agencies weren't communicating well, and you can see it. The reason I tell you this is because if you're doing a long cohort, so if you're tracking something and doing death, and you're going back before 09, let's say 09 forward or 11 forward even, you're going to want to watch this. This is going to be an issue. If you're using more contemporary data, 2015, 2016, I don't think it's an issue, and I wouldn't worry about it personally. So if you retake this course in about 3 years, we probably won't even be talking about this because it really won't be relevant. But these are the sort of secular changes in data quality that matter. So one of the things that I routinely do when I'm doing studies is I'm spanning years, is I will often plot things over time to make sure, as Nate showed with the example of the CPT codes, that there isn't some secular trend that has nothing to do with what we want, but could interfere with what we find. So this is an example of that sort of pattern. Again, this is just more showing the same. In terms of race, previously, back before 94, back when I first started using the data, race was coded as white, black, other, and unknown. And in 94, race was expanded to include white, black, Asian, Hispanic, Native American, other, and unknown. This was at the point when there was a recommendation from the National Center for Health Statistics that we measure race and ethnicity separately. What happened in 94 for CMS is they couldn't figure out how to add an extra column, or it was too much work to add an extra column to the data table. And so they just changed they just added Hispanic, and so they're mixed together. If you think this is crazy, this has to do with why Y2K was so much trouble for those of you who are history majors. So this is still not in line of OMB requirements, but I don't see it changing anytime soon. The challenge we have is that the Hispanic race ethnicity code has an estimated sensitivity of about 35%. So our problem is, very bluntly, that we can't measure what we need to measure. So what happened is there was a RTI, Research Triangle Institute, got a contract to update some work that had been done, University of Miami, where it was shown that you could use a surname identifier. So what happened is that running an algorithm for Hispanic surnames changed sort of the sensitivities. We used, as an example, Puerto Rico, which is a Hispanic territory of the US, and found that using the CMS race code between 22 and then more recently down to about 16% of residents of Puerto Rico were identified as Hispanic, but using the surname RTI race code or the surname identifier, almost 100% of the people in Puerto Rico are Hispanic. So we can have conversations about people changing their name and being adopted and all of this sort of stuff. But the point of it is the RTI race code takes into account, uses a surname identifier algorithm. The CMS race code uses self-identification. So when we look at the concordance of race over time, because this has to do with, well, what happens and what can I decide? One of the things we found was that, and you can basically, the concordant race isn't changing. So we hear about updates, the reality is that the concordance between RTI and race code between 2019 and 2010 isn't changing. They're rarely updating it. So you may read about a code being updated, you may read about an algorithm being reproduced, but in fact, if you notice, it's vanishingly small that anyone's race will change as far as CMS records go. So this has to do with this reliable thing. And it means that if you're looking at a cohort over time, in my mind at least, I don't worry that if I pull race from one year versus another, that I'm going to get a different answer for a particular person. Now, that said, residency is a completely different beast. So with residency, there are both annual and monthly variables. And they have their craziness in a few ways so this is actually important to look at. So on an annual basis, the file contains the state, county, and zip code of residents that are the mailing address for official correspondence. We've done, and others have done, analyses comparing state of treatment with state of residency, which isn't perfect because sometimes people cross state lines just out of convenience. And it shows very, very high concordance. The denominator, or the MBSF file, is based on, the values are based on when at the last date of the calendar year. But the important piece here is it uses Social Security coding of states and counties. So, and on a monthly basis, we can have the state and county code of residence, not zip code, you understand. And they use FIPS coding. So the other craziness here. So annually, you can get a zip code. Monthly, you can get a state and county. Annually, we'll be using the Social Security codes, and monthly, we'll be using the FIPS codes. FIPS and Social Security alphabetized differently because it has to do with when they count, for example, Guam. And so if you start finding that people move from, from Georgia to Kentucky, sort of weird moves like that, then you probably are mixing SSA codes and FIPS codes. So again, you've got to watch this. You've got to watch it carefully to understand the coding of states in claims files for providers and the coding of states in the denominator. If that makes, so that is a craziness that you just have to watch. But it also, if you start getting really weird moving patterns, this is the likely thing. And I say it with a fair amount of confidence because I've experienced it multiple times. So now a polling question. I don't. Okay, we'll give it just another minute or two. Okay, so I'm going to end the poll. So right now, about 68% of you think it doesn't solve the problem about finding Hispanic elders, and the remainder, 32%, think that it does. So if somebody wants to in chat, just put what they voted and what they think. I think these are the sorts of questions we need to really worry about when we're interpreting variables. So if somebody wants to just share their thoughts, we can take just a minute to sort of review that. Okay. So Catherine thinks yes. So Catherine, do you, and so does Debbie. Do you guys, so you think it's accurate enough? Kenneth wants to answer they use an algorithm solely based on last name. Yes. Or a last name plus Hispanic indicator. I think they put the two together. So for the 68% of you who doesn't think it answers, anybody want to weigh in on why they think it's not enough? Can a beneficiary be identified as both Black and Hispanic? Yes, you can be identified as both Black and Hispanic because your Medicare identifier would say Black and your surname identifier would say Hispanic. So it does allow for that. Though you do have some people who are Hispanic and Hispanic. So if that makes sense. So if somebody, so for the people who are already identified by Medicare as Hispanic, you cannot differentiate white and Hispanic or Black and Hispanic or Asian and Hispanic. Thomas says that last names change and can be so wrong for identifying, and you think it's biased, self-identity, interethnicity, marriages, etc. So what's interesting is that one of the things that happened when they were first doing these polls, when they were first trying to update this, they would send letters to people saying, this is the government, are you Hispanic? And they started off with very high Hispanic population areas. So for example, I was in Miami at the University of Miami at the time, and these were coming in, and you get these people who'd be like, we're not answering that because we think it's like something to find illegal immigrants. And there was a lot of suspicion. Please tell us if you're American Indian. So I think the challenge we've got is that, yes, it could include Hispanic. It would miss Hispanic elders who don't have Spanish last names. It would get people who marry in and do. So there's certainly some missingness that would happen. So sensitivity would be good, but I'm not sure about specificity. So I think these are the sorts of questions that we're all facing now when we think about race and ethnicity and how we measure is what do we do with this, and is it close enough? What exactly do we want to do, and what should we do with it? Do we ignore it? Do we use it and acknowledge the limitations, or do we ignore race altogether? But these are the issues that ResDAC can't help you with. In other words, we cannot tell you how to interpret this variable. We cannot tell you, oh, you should use it, oh, you shouldn't. But in fact, these are the places where we need to spend our time thinking. The entitlement information. Now we're going on. So the entitlement variables can be useful. So first of all, we've got a field called original entitlement. And the original entitlement field has values old age, disability, end-stage renal disease, and disability plus end-stage renal disease. So, and then current entitlement is the same. So for example, you could find somebody who is disabled but aged into the old age program by saying if original entitlement was disability and current entitlement was old age. So you could use that to create a flag to differentiate between the people who were disabled and aged into Medicare and the people who just got it because of age. Some things to think about is the ALS is tricky. There is no ALS identifier. You're going to have to use it. You're going to have to come up with it. So if the person is less than 65 with ALS, they'll be categorized as disabled. If they're greater than or equal to 65, they'll be categorized as old age. So in fact, what you will need to do is you need to do a combination. We got a question of why does end-stage renal disease get called out when there's so many other diseases as severe? I don't know. So that's Jennifer's question. I think it has to do, my guess would be with either the sort of the organ transplant program or somebody who lobbied Congress. Because remember, the Medicare program is run by Congress, but I honestly don't know the history of it in terms of why it is picked and what other options it should be. We can think, but again, there are plenty of other conditions. There certainly are that are, as you would say, that are just as severe, that where people would really benefit from the same level of coverage. So I think it's probably a more complex story. So when we look at current reason for entitlement, again, just reminding you, 86% are elderly, 13.7% approximately are disabled, and 0.2% are end-stage renal disease only. Most end-stage renal disease will be end-stage renal disease plus disability. Just remember that the current reason for entitlement and end-stage renal disease do not perfectly correlate. So if you want to find end-stage renal disease people, you need to do some more. It isn't just going to be the end-stage renal disease indicator, and there will be people with end-stage renal disease who are not. So there's mismatch in both ways, and I would actually suggest the US RDS, the US Renal Data System, is a good source of information on the renal dialysis program. ResDAC can also help, but just do know with all of these indicators, there is some slippage, and in some cases you get things that don't line up perfectly. And the reason we tell you this is not to do extra categories, but if this is something you care about, a reminder that you're going to need to spend the time actually sorting it out and understanding and making some tough calls. The Medicare status code is a monthly code, and what it does is it rolls together end-stage renal disease and disability. So, but just also remember, for example, not enrolled as a status means they are not in that month enrolled. It could mean because they have died. It could mean because they were 65. They have not yet turned 65, but they're going to turn during the calendar year. So don't forget the not enrolled and that it means two different things, but that you can combine on a monthly basis so you can identify when exactly somebody became Medicare eligible. One of the things that drives me crazy personally when I review articles is people who just take the whole Medicare program and just dump it into a big bucket. And what I want to point out to you is that the three benefit programs are very different. And so when people say, I took everybody in Medicare, you will get answers that aren't necessarily indicative of any one of them. So for example, as we've shown you with the elderly, it's about 45% male, disabled 50%, 51%, and end-stage renal disease is interestingly 58%. It's a male-dominated condition. But look at the difference in annual mortality. Elderly is 4%, disabled is 2%. So these are chronically disabled, low mortality. That 24-month waiting period practically guarantees these are low mortality conditions. And end-stage renal disease only about 7.6%. So that's the highest mortality. If you look at our ages, the elderly, the mean age is 75 years, where the disabled and end-stage renal disease, the mean age is in the 50s. If you look at the top DRG, the elderly, it's septicemia, the disabled, it's psychoses, and for end-stage renal disease, it's this miscellaneous disorders of metabolism, fluid, and electrolytes, which is where all of the dialysis falls. So you can see these are different populations with very different profiles. So if you read an article that says the mean age of my population was 67 years old, and what you know is they have taken all three groups and just glommed them together. And so then what the question that I think you need to add is, do you really intend to put all three groups? Do you think they all belong together? Or do you think perhaps we should be breaking them up and thinking of them separately, more of a stratified analysis? So you can figure out my bias, but again, just to point it out so you make your own decision. The Medicare benefits. So this is the next segment, the base segment. As you remember, we've got Part A, Part B, we've got Part C and Part D. So again, we know that these are going to be overlapping in that grid that I showed you this morning. So most beneficiaries have Part A and Part B, but 91% have both Part A and Part B at some point during the year. 2% have more months of Part A services than Part B. One of the things that I've noticed is that often when people are first enrolled, it can sometimes seem like their Part A hits before their Part B. So I think that just has to do with timing of when somebody finds out they're eligible and starts their Part B, where I think sometimes Part A starts a little bit earlier. So when you're using an algorithm that says equal months of Part A and Part B, for new enrollees, I will sometimes allow just a little bit of latitude there. Remember, beneficiaries are not required to have Part B benefits. And so people, up to almost 9% of people will have only Part A at some point during a year. Again, it can be for a variety of reasons. Some people, that's all they take. But also remember, Part B benefits can be waived if you can show that you have other health insurance that's comparable. So if somebody is still working and they have benefits through their work that is comparable to what Medicare would provide, they can waive their Part B without penalty. So we talked about the penalty this morning, but this is the one exception. The challenge we have is we cannot see whether or not they had permission to waive it because of this or not. So we only see more Part A and Part B, but we don't see why. Question is, does this mean 1% of patients with both parties? No, it doesn't. The two numbers are a little, the 1.9% is a little confusing. I think we're trying to be too precise sometimes. But what it does mean is you will find people who are Part A only. And the challenge you have with them is to figure out what to do with them. And I'll go into that in just a second. So the monthly enrollment status, Medicare benefits, like insurance, are determined on a monthly basis. CMS gathers and maintains the information, including Part A, B, C, D enrollment and disenrollment. The challenge we have is that hospitalization rates for Part A, so we say, well, Part A is an entitlement, but in fact, Part A hospitalization rates depend on whether or not somebody has Part B. So for example, the hospitalization rate for people, let's take 75 to 84. The annual hospitalization rate for people with A and B benefits is 30% compared to 12% with people who are A only. So to me, what that says is that people who are A only aren't relying on Medicare for their health care. They've got something else that is a primary payer. And so what that makes me nervous about is, even though I can be pretty confident that the hospitalizations I see are real, I worry that I'm missing some. And I'm worried that I don't know what I'm missing and I don't know how to interpret it. Could be veterans in the VA system, could be people still working, it could be people with a working spouse. What is it? Harrison Ford's wife is in her 50s. She could have a job. It could be somebody who's in the Indian Health Service. It could be somebody who thinks doctors are evil and just doesn't see anybody. But the problem is we don't exactly know who they are or why we're not seeing them. So we don't know how to interpret it. So these are the things that worry me. And these are the things that we spend our time whenever I do my research, trying to make decisions about how, for each particular study, we want to handle it. Now, we talked earlier today about dual enrolled Medicare and Medicaid. So remember, every state exercises the option of paying the Medicare premiums for at least some people. So about 18% overall, and we pointed out earlier that it varies by state, receives some state assistance. The state assistance can be in three forms, roughly. The state pays the Part B premiums. The state pays the premiums plus cost sharing, that's copays and deductibles, or the state provides full Medicaid benefits. So the last one is the most common, but the other two are also important. These are noted in the file as state buy-in. So the state buy-in variable means that the state helps. No, it's not 18% of duals. Because duals are technically Medicare and Medicaid both, Thomas. So you are not a dual unless you get full Medicare full benefits. So there is, again, not everybody is equally precise in what they call it either. The state buy-in data. So the state contribution is the state tells CMS directly. So the point of all of this is that CMS bills the state instead of the beneficiary. So the beneficiary won't get premium notices, and if they get help with cost sharing, they won't get the bill saying you owe a $15 copay or a 20% copay. That will all be sent to the state, and the beneficiary themselves won't even know about it. So the states and CMS communicate very closely for these people. In the MVSF, you will get a bit of information that you have to use carefully. So there'll be a summary count of total months of, quote, state buy-in. There'll be Part A state buy-in, Part B state buy-in, or both. And for each month, the entitlement buy-in indicator will summarize what it is. So it'll be not entitled, which again means they're not in the state. They're not in Medicare at all. They will be Part A only, just that's all they have. They'll be Part B, be Part A and Part B. So that's the typical beneficiary. Or there'll be Part A state buy-in, Part B state buy-in, and Parts A and B state buy-in. So threes, Part A and Part B, and C's, Part A and Part B state buy-in are the most common that you will see explaining entitlement and who pays. Yes, so you could use, so for Emmy, you can see that these variables would allow you month by month to know exactly what somebody has. But I do want to point out, and this is another one of my ticky things, state buy-in is not the same as poverty. So when we use the MCBS, we compared surveys, only 66% of the people who reported incomes below the federal poverty level were state buy-in. So there's a lot of people who are poor, who report being poor, who are not getting help with their premiums and copays. Likewise, 43% of the beneficiary who get state buy-in report incomes above the federal poverty level. So what it means is that when you read the articles, people say we adjusted for poverty. What they're adjusting for is state buy-in, which is adjusting for somebody making it through a process. And so we've got to watch that because it's not the same. And people will ask, what poverty variables do you have? And like disability, to get this indicator, you have to both need resources and perhaps have access to resources in order to make it through a process. Minhee asked whether we can recommend a good resource to see different state policies for duals. Maybe the Kaiser Family Foundation webpage, kkf.org, I think is what it is. I think this is one of these things that's hard to do. The state policies are all over the place, and it's hard to track them all down. And the states don't always use the same language. And even when you do find a summary, if you've got a particular policy you want, you're going to want to make sure that you report it, that you investigate it. So Kenneth asked, what's the interpretation of beneficiaries with state buy-in but incomes above poverty limits? And I think the answer could be a couple of things. It could be that they're in larger households. So even though they have a higher apparent income, that income is covering more people. So we read about grandparents raising grandchildren. The MCBS doesn't ask how many people do you support with your income. So it could be that, it could be people not reporting their income correctly, not remembering, not using the right adjustment, adjusted versus unadjusted. So I think it could be a number of things, or it could just be that different states have policies, and so the other factors besides poverty go into that consideration. But again, my advice would be, if you're going to use state buy-in as an indicator, use it as an indicator, but try not to call it poverty, because if I get asked to review, I will complain. That's how you'll know you got me. The other thing beginning in 06, and this is a mixed bag, you actually get the exact program somebody is in. So we talk about state buy-in, but in fact, there are different codes that show what benefit they have. So there's what are called QIMBs, qualified Medicare beneficiaries, SLIMBs, specified low-income Medicare beneficiaries, SLIMB and Medicaid, including prescription, qualified disabled and working. I mean, these programs are all over the place, and they're super technical. And if you're interested in knowing exactly which program that somebody is in and what it means, we've got a link here of the definitions. CCW on the file page talks about how they roll up some of these for reporting, so you could look at reports. But these are really confusing, and the times that I have spent trying to categorize them and figure out why certain reports put them a certain way have been really, really challenging. So I know that's not exactly what you want to hear, but so now for a polling question, just to get a bit of a break. Okay, we're going to give just a couple of seconds more for the last people. If anybody else wants to plug something in. And the poll here, share the results. So as you can see, do you need to do anything extra to get cause of death information from CMS? The answer is yes. So there's a couple of things you'll need to do. You will need to justify why you need it and have a reason. The reason has to be specific to how cause of death, so not just like it's useful, but like I need to differentiate between cancer-related and non-cancer related mortality, or I need to understand where people who, so you've got to have a reason why people who have sustained certain injuries, whether they're at greater risk of cardiovascular problems or whatever. So you need to have a scientific question that does it. And that's a mix of CDC rules and CMS's rule, which is minimum data necessary. So you need to have a reason. And then the other piece you need to do is you need to make sure that you get it in the right data system. And as we said earlier, that means you've got the arrangements to use what's called the VRDC or the online portal rather than the physical copies of the data. So the answer is you do need to do extra work to get it. And most of it is really coming up with the scientific rationale. The The security that we used to face when we had physical data is no longer an issue because of the change in policy about data storage. So with that, we're going to talk about Part C. So that was sort of a non sequitur a bit. Enrollment considerations. So managed care enrollees are required to have both Parts A and Part B, and almost 100% do. Every once in a while, somebody tries a demonstration project, a VA demonstration project or something, but really that is settled to, it's no longer, the question of Part A only is pretty much gone. Managed care enrollment organizations transmit enrollment and disenrollment data as well as corrections to CMS. And that is the basis for the monthly premium they're paid from CMS. What we get is we get a monthly HMO indicators and summary counts of months of coverage. And with the more recent data, we actually can find out information on the contract number and the plan benefit package. So we can actually see not just are they in managed care, but are they in the same contract or the same plan time year to year. So, and we can distinguish among different plan types, HMOs, HMO POS, PPO cost in more detail. So we actually know more about what people are doing in managed care than we used to know. So if you care about those decisions and perhaps what those decisions mean, we now can see it. So it's less of a black box. There is this thing called risk managed care organizations, and this is somewhat historical, but it's important that you understand. And risk managed care organizations are paid the monthly amount. So this is what we have now to cover all costs, all Medicare services except hospice. You remember we talked about that. They also, as part of their contract, may agree to provide additional services. They may agree to provide hearing aids or dental, wellness exam, and so on. And that's all based on the contract. So that's where knowing the contract number can be useful. There used to be this thing called cost managed care plans. And they show up and they're, from an inference perspective, more challenging. And they were a hybrid product that CMS created with the idea that they thought the savings was more in the special things that the plans did to manage their populations than it was in their ability to process claims. So for cost managed care plans, CMS processed hospital, skilled nursing facility, outpatient claims, and some types of carrier claims. So they processed some of the stuff, but not all of the stuff. And the idea was that what they were playing the plans to do was to manage the population, to do the wellness magazines, the special services, but CMS could do the data processing more effectively. The challenge for those plans is that we see some things. We see hospitalizations, we see skilled nursing facility claims. But we can't, so we know what we see, we just don't know what we don't see. So again, it's this idea of what do we do when we have part of a picture? Can we work with it or not? Cost managed care plans were not found in every market. Some markets had a big cost presence, some didn't, and they've now been phased out. So if you look at managed care enrollment, you will sometimes see some markets that had a big jump, and that was when the cost plans were phased out. So when you look at the monthly HMO indicators, not enrolled in managed care is steady at 39 to 40 million. Now do notice that not enrolled in managed care can mean one of two things. It could mean they're not enrolled in Medicare in that month because they died or because they're not yet 65. Or it could be they're enrolled in original Medicare and they're not enrolled in HMO. So you've got to be careful when you use these indicators. And then we've got all of these CMS to process claims, and you notice that's going down from 500,000 in 2013 to 265,000. And then we've got other sort of weird categories that aren't really used anymore, but the values will show up in the database in the record layout. And then we've got Cs, which are lock-in group health organization to process all provider claim. And that is where the standard managed care is. And you notice between 2007 and 2019, that went from 8.4 million to 22 million. So that is where our traditional managed care people are. They are Cs. They're lock-in, and the cost managed care, which is non-lock-in, has been phased out. So as you're looking at a period over time, this is again where we're seeing these secular trends, and you're going to have to figure out how to manage them. Part D, and I'm running behind as I sometimes do. We know on a monthly basis, enrollment, the plan contract and benefit package, whether there's an employer-sponsored drug subsidy and market segment covered by the plan. We can know the plan type, and we can look at enrollment. So notice for managed care, 97% are ABD. For fee-for-service people, it's about 58% have ABD coverage. Another 27% have AB, 14% are A only. So there are differences between fee-for-service and managed care and how pharmacy fits in. We have the chronic conditions and other potentially disabling conditions. These are variables which indicate the presence of treatment for common chronic conditions using algorithms. Nate will talk about these algorithms in much more detail tomorrow. And the information is present for all beneficiaries in the sample, regardless of whether they have the conditions. And they include mid-year, annual, ever flags for these conditions. Just remember, and again, Nate will talk about it tomorrow, and since I'm behind, I'm going to go a little bit faster. These may not be as precise as you want, but they do use a common documented approach. If they're well documented, you can see this, but just do know they have conditions like diabetes, hip fracture, asthma, depression, epilepsy, and so on. The cost and use segment contains summarized patient-level utilization information by care settings for the calendar year. So acute inpatient Medicare covered stays and payments, dialysis events and dialysis payments, hospital outpatient emergency room visits, and so on. So these again are algorithms that are well developed, well documented, and if the algorithms work for you and work for what you're trying to do, these can save you an awful lot of time and a lot of time processing data and creating algorithms. So take the time to look at these and to figure out if they're going to serve your needs, and if they do, they can be a wonderful resource. But as with anything, they may not be as precise as you want. They generally don't include services for managed care enrollees other than Part D events, and variables will be missing if they didn't use this type of service during a year. National Death Index segment. It's again, the data obtained by the CDC National Death Index includes information on date of death, state of death, and ICD-9 code cause of death. They're available for known Medicare deaths from 1999 to 2021, and they require additional approval from the NDA Advisory Board, and they can only be accessed through the VRDC. The process has been streamlined because CMS does the linkage. So it used to be that we had to work to figure out how identifiers would be transmitted, and that's all been done for us. So the process, even though the advisory board will look it over and make sure there's a scientific reason, a lot of the part of doing an NDI linkage, which has to do with identifiers and linking algorithms, has been taken care of for us. So this is a massive benefit. Just keep in mind, about 98.4% of the deaths also for 2016 were also in the 2016 MDI segment. So again, very high levels of linkage, and only less than 1% had a difference in date of death between Medicare and the MDI, and the median difference was 1 day. So again, I've got high levels of confidence in these data, and everything we're seeing is showing consistency between the two sources. And that polling question, the NDI polling question, I think we did in the wrong place, so I apologize. That was on me. So key takeaways. The denominator, the MBSF, is always useful. You always want it. Provides valid demographic information. Enrollment information is a great way to define cohorts, population, set inclusion, exclusion criteria, can help support stratified and sensitivity analyses. So these are important when you're trying to make sure you know sort of what population you're trying to generalize to. Medicare status codes 10 and 11 are a good way to identify the elderly. Most of the time, we like to limit ourselves to what we would sometimes call likely to have complete claims. And these are people who are pretty confident that what we're going to see is going to represent the universe of what people had. So in this case, it's both Part A and Part B coverage and no managed care enrollment. Just think about sometimes you're going to want to look back period. So 1 year, for example, 1 year before to 1 year after a hospitalization, 3 months before. Some cases we're going to want to say, we want to exclude the preoperative period to get a baseline comorbidity measure. If you want to consider Part D, remember there is some non-random pieces about Part D in terms of how it links to age and what coverage people have. But again, the MBSF is a great way to start pulling that population and to make sure when people are expected to disappear or appear. This is a sort of a classic story, and this happens regularly and with a variety of files. Some people will call us up and they're like, I was looking at the file and it's going down, but I know what's going on with the boomers and this is going in the wrong direction. And this is an example from 05. It's not the first one we've used. It's not the last one, but got this call and they're like, the carrier file's getting smaller, fewer people in it, but it's supposed to be getting bigger. Is there a problem with the 5% file? And this is a fair question to ask. So what we did is we looked actually at the denominator at the time and said, no, the denominator is getting bigger. And what was really going on is the denominator was getting bigger and the carrier was getting smaller. And the reason was that the managed care enrollment was increasing faster than the overall population, which resulted in a net loss in the carrier file. So these are the sort of things that happen where having the denominator allows you to understand these patterns and why something is rising or falling and what is it so that you can interpret it more accurately. So with that, I'm a couple minutes late. Are there any questions? If not, why don't we're scheduled to come back at 2 o'clock. So you lost a couple minutes of your break. And again, I will be on and we'll answer things through chat if you've got any questions or if there's anything else. And again, I'll be back tomorrow as well. So with that, thank you.
There was one question that came in the Q&A about addressing missingness in the annual zip or monthly FIPS.
Sorry, what did you say, Steph? Do you mind? I just didn't miss the first part of it.
Sure. So they're looking at the annual zip code or the monthly FIPS code, and they're finding a lot of 99999 zip codes, and they're wondering about strategies to address that missingness.
I've got to be honest, I would probably check, first of all, to see what the state said. So it could be, for example, these are people who are living outside of the United States, so the zip code would be missing. So I would probably start by looking to see if there was a pattern to that missingness, such as, is it people who are living outside of the US? There's a big move, I guess, Costa Rica and Portugal are great places to retire, I'm told. The other thing would be to try to figure out if there's something about the people who are missing. So are these missing at random or are these missing not at random? And the reason I usually start there is often what I find is when I have a problem, it turns out it's not a widespread problem, but it's actually a sign of something. And then I'm better able to figure out how to handle it. So that's probably where I would start. I don't know if you've done that already. But those are the biggest reasons, because again, the zip code is taken from the mailing address for official correspondence. So zip codes tend to be valid a lot. Steph, do you have other ideas?
No, I think I agree. It looks like you're already looking at a couple of different sources of information. Sometimes that is another strategy that we use within the claims is, are there other ways to get that information? And then the downside to doing that is that what do you have to then resolve if they give you different answers? But yeah, I think that making or trying to understand the reason behind, or if it's a widespread problem, or if it's, you know, in a specific population, is also really useful.
I guess, you know, there's one other thing to point out. I don't think I've said it yet, and I'm not sure, Nate, if you have yet, but with these data, when the files are so big, it's really important to do a percentage, because sometimes you can get what seems like a very large number, but is in fact a very small percentage. So it could be, for example, that, yeah, you have 1,000 of these, but they represent, you know, less than 0.1% of everybody. And so that's the other thing that we sometimes have to do, is to say, well, I could spend a lot of time sorting these out, but it's unlikely, when I consider the population percentage that they are, that it's actually going to be worth the amount of effort it takes. And so as long as I'm convinced they're missing at random, I'm okay having them missing. It's knowing whether, so for me, often my first question is, are they missing at random or missing not at random? And I'm much more comfortable having a very small percentage, even if it seems like a large number, as long as I'm sure I'm not doing something systematic. So I just want to point that out, because I've gone down that rabbit hole too, have spent massive amounts of time and then realized that it really didn't change anything. That would just be one other thing to consider.
Yeah, and that's, I mean, I'm mostly just agreeing with you, Beth, but I know that in working with the analysts, when we are, you know, trying to figure out a given field in the data, it's very, very, very common to have somewhere between about 1% and maybe 4% of just general weirdness. And that's just really, really common. And so it's often not likely that that's going to change your overall, you know, takeaways, the overall scientific contribution of the conclusions that you're making. But it's incredibly common across the variables, that even a really good quality data quality variable will have some small percent of just weirdness in it. It just happens.